Hello, my name is Jean-Jacques Kiladjian. I'm a hematologist in Saint-Louis Hospital in Paris, France. And I will discuss today about the new information using ropeg interferon alpha 2B, which is a new generation interferon alpha that has been approved recently in Europe for the treatment of patients with polycythemia vera. Indeed, this year we had two important new information with this drug. First, the 4-year results of the PROUD and continuation PV, that were the registration studies of ropeg interferon in PV, showing that after 4 years of treatment, the responses we see with this drug, in particular complete hematological response, are durable, with more than 60% still in complete, 60% of patients, still in complete hematologic response after 4 years of treatment, compared to less than 40% in the control arm. The second new information with this long-term follow-up is that we see now a huge difference in terms of molecular response, with more than 60% of patients achieving molecular response in the ropeg arm. And importantly, for the first time, 13% of these patients achieved complete molecular response, meaning that their JAK2 V617F mutation is no longer detectable. None of the patients in the control arm could achieve such a response. The second new information with ropeg comes from Professor Tiziano Barbui and a low PV trial in Italy. Indeed, they performed a clinical study randomizing ropeg interferon compared to conventional therapy, meaning only phlebotomy and low-dose aspirin for patients with polycythemia vera at low risk, meaning that they're both younger than 60 and also never had any vascular events. This trial was planned for an interim analysis that was performed and presented at the EHA meeting with very good results, including that this interim analysis allowed to close inclusions because the primary endpoint was already met. The primary endpoint was a composite endpoint with combining control of the hematocrit below 45% without phlebotomy and no disease progression. And indeed, 84% of the patients in the ropeg arm achieved this primary endpoint compared to 60% only in the conventional treatment arm. In addition, there was also a significant benefit in terms of symptoms for the patients receiving ropeg compared to those treated with only phlebotomy and low-dose aspirin. So altogether, we have now this year interesting information in both high-risk and low-risk PV patients that should maybe prompt the reassessment of the management guidelines for low-risk PV patients.